Welcome, everyone. Thank you so much for joining us today. My name is Dr. Louise Ivers. I'm a professor of medicine and a professor of global health and social medicine here at Harvard, and the faculty director of the Harvard Global Health Institute. It's my pleasure to welcome you all to HGHI's Global Health Research and Innovation Speaker Series. This monthly series is hosted by us and designed to showcase the latest advancements in global health research, with the goal of fostering dialogue and elevating innovative solutions that advance health outcomes worldwide. We welcome you to continue joining us for more discussions every month. I do have a few notes. The session is being recorded through Zoom, and the recording will be made available on the HGHI website and YouTube page in the coming days. We plan to have time at the end of the presentation to answer your questions. If you have a question for our speaker, you may submit that through the Q&A feature on the bottom of your screen, and we'll do the best we can to get to those later in the event. So with that, please allow me to introduce our speaker. I'm delighted to be joined by Dr. Al Ozonoff. Dr. Ozonoff will be presenting on Sentinel, strengthening surveillance capacity in West Africa for preparedness and response. Dr. Ozonoff is a scientist trained in mathematics, statistics, epidemiology, and data science, focused on improving population health through better surveillance of disease. His work spans public health, infectious disease, and hospital-based surveillance. He has over 2 decades of research experience and has co-authored more than 200 peer-reviewed publications. He completed his doctoral training in mathematics at UC Santa Barbara and his postdoctoral work in biostatistics at the Harvard Chan School of Public Health. He has led multiple federally funded projects, including a CDC project on methods for syndromic surveillance and an AHRQ-funded project to conduct patient safety surveillance using machine learning. During the COVID-19 pandemic, he directed the Clinical and Data Coordinating Center for IMPACC IMPAC, a national immunophenotyping study funded by the National Institutes of Health. At the Broad Institute, he directs the Sentinel program, which aims to strengthen surveillance capacity in West Africa. We're thrilled to have him with us today. It's my honor to hand the microphone to you, Dr. Ozonoff. Thank you so much and welcome.
Thank you so much for that introduction, Louise, and thanks everyone for being here. Let's see, I'm going to share my screen and start my presentation now. And if there's any trouble seeing these slides, please let me know, but I'm going to assume everything is working well.
Looks great.
Great. So I'm really pleased to be here, and I should say at the beginning, I have no conflicts to disclose, and I'll be speaking about the Sentinel program, which I've directed for about 3 years since I joined the Broad in 2022. Let's see, great. So I like to start off, and I'm going to be talking a lot about surveillance, and my training is in surveillance. My background is in surveillance methods. Stephen Thacker, who's an epidemiologist at CDC in 2002, said surveillance is the cornerstone of public health practice. And so I've adapted that to say surveillance is the cornerstone of pandemic preparedness. And when I talk about surveillance, I use a very traditional definition, again, from the CDC. It is the ongoing and systematic collection, analysis, interpretation, and dissemination of health outcome data for the purposes of public health. So in that context, I'd like to talk about the Sentinel program, which is aiming to strengthen surveillance in West Africa. First, let me say a little bit about the context here. So when we work in West Africa, it does feel like we're on the front lines of emerging infectious diseases. And you'll see this diagram here, which came from WHO, illustrates the number of outbreaks that happen, in this case, mainly viral hemorrhagic fevers that happen in the areas of West and Central Africa. In many ways, it's a hotspot for emerging infectious diseases. And here's just a few of the outbreaks that we've experienced in recent years. The Ebola outbreak in 2014, 2015, some of you may remember that. It was a very serious event, resulted in 11,000 deaths. and actually quite a lot of disruption as some cases made it out of the region, including to the United States. And as recently as 2023 and 2024, there have been major outbreaks of Lassa fever in Nigeria and Marburg virus disease in Rwanda. There's an ongoing outbreak of Mpox in Sierra Leone, and I'll speak a little bit more about that at the end of the presentation. So we're talking about a part of the world that is in many ways a hotspot for outbreaks, including many pathogens of pandemic potential. And what's very challenging and also worrisome about this context is that this is also a part of the world where there are systematic and systemic gaps in staffing, training, and infrastructure experienced across many of the countries in the region. And I think that's broadly true of LMICs across the global south. And so this creates a fairly high risk situation where surveillance capacity may not be as strong as it could be. And yet there is probably a higher risk of an infectious disease with pandemic potential that emerges from the region. So in this context, we think about the absence of accurate low-cost diagnostic tests, robust data systems, and trained public health professionals as key factors that leave communities vulnerable to disease outbreaks. And it's in the spirit of the Broad Institute thinking about how technology and innovation can make the world a better place with respect to health, that we've started the Sentinel program, really bringing technology and capacity building to the region in order to make a self-sustaining and stronger public health infrastructure in West Africa. The Sentinel program, actually, its roots go all the way back to 2014, 2015. And here in this picture, you see pictured on the right is Pardis Sabeti, who leads the lab. Pardis is a core institute member at the Broad. And on the left is Professor Christian Happy. He's a professor at Redeemers University in Nigeria. And Pardis and Christian have been working together for nearly 20 years and founded Sentinel as a partnership. It's a co-led by those two individuals, but really represents a partnership between the Broad Institute and what at the time was ACEGID, the African Center of Excellence for Genomics of Infectious Disease, founded by Professor Happy. ACEGID is now named the Institute of Genomics and Global Health, or IGH. And so this partnership between these two institutes it really is the foundation for what we do in the Sentinel program. As I mentioned, we work in West Africa. For the most part, Nigeria and Sierra Leone are where we are most active. We have established some activity in Senegal, and we are in early stages of collaborating with Liberia and the DRC. And so as we think about where we work, we're trying to expand at a reasonable pace because we want to make sure that we can maintain our program structure, but we're really aspirationally would like to bring our activity to the whole regions of West and Central Africa. We believe really strongly that, the only way that our work will be sustainable is to work hand in hand with local, regional, and continental partners. And so here are some examples of the groups that we work with most closely, including WHO Africa, the African Society for Laboratory Medicine, Africa CDC, and Nigeria CDC. Sentinel operates on a hub and spoke model. And so what we can imagine in each country that we work in, we generally try to establish a base of operations, a hub, which includes laboratory facilities. And that laboratory hub will be connected to a number of spoke sites, generally sites at health clinics. Often these are clinics in rural areas. And so maintaining connectivity with the hubs is challenging. I mentioned at the beginning, we think about testing, data systems, and training and capacity as the three main pillars of our program. So when we talk about laboratory hubs, we're thinking about how to improve the capacity for testing at those hubs. When we talk about data systems, we're talking about how to provide our clinics with testing capacity, but also the capabilities to transmit data back to the hubs and how to coordinate data across the networks. I think ultimately what we hope to do in partnership with groups like Africa CDC is to establish going from country level networks to a regional network where we can really imagine cross-border surveillance and cross-border response. Certainly, Africa CDC does a good job of coordinating response across the region now. That's one of the purposes of Africa CDC. And we think that, as partners with Africa CDC, we can have a place to play in sort of connecting our various country networks, complementing what Africa CDC's role in coordination across borders might be. So I talked a little bit about surveillance, and I do want to say something about technology. And my background is in surveillance methods, and I used to teach a course on the surveillance methods, including the history of surveillance. And I used to say, I think that methods did not change a lot, at least the technology behind surveillance didn't change much from the 1800s to the 2000s. And we see this photo on the bottom left. This was from the late 1990s, and this would be a typical provider office in the United States filled with paper records. What's been really interesting in the time that I've been working in the field is to see that there has been a sort of technological shift in the way that we do surveillance with the advent of electronic medical records, computing, information sciences, public health informatics, and eventually what we started to call, and I think we still call, the age of big data. And that started to transform the way that we performed surveillance. It's been a very interesting time for me to see these technological changes make their way into public health practice. And part of the premise for what I'm talking about today is that genomic technology is achieving a similar shift in the way that we conduct surveillance. And so really a lot of what I want to talk about in the context of the Sentinel program is how we aim to bring genomic technology into the mainstream of public health practice. In particular, how can this technology improve surveillance? So our roots are in genomics, and when I say our, the Sabeti Labs roots at the Broad are in genomics and computational biology. And so there's a whole stack of related technologies. We've targeted diagnostic technology, computational tools, and to some extent, although I won't talk about it today, vaccines and therapeutics as areas that will probably benefit the most from bringing state-of-the-art technology to these important aspects of public health. One of the things that we learned, I think, during the pandemic is that effective surveillance really depends on testing capacity. And at the Broad, there was hundreds of thousands of tests performed over the course of the COVID-19 pandemic. We learned a lot about how to improve testing pipelines, high throughput, how to handle aspects of scale in diagnostic testing. We're trying to bring some of what we've learned, both in terms of technology and workflow, to strengthen and support surveillance capacity in West Africa. And that's really what Sentinel is all about. So when we talk about testing, we're thinking of testing both at the point of care, so maybe at a health clinic as patients arrive, but also in our central laboratory hubs where we can do much larger scale screening, hundreds of samples at a time for multiple pathogens. And the large scale testing in that way, we've achieved that during the pandemic for COVID. It's actually a very challenging problem to think about how to do this in a way that is low cost, accurate, affordable, and sustainable for public health systems, for example, in West Africa. I just, in the interest of time, I don't want to spend a lot on sort of our detection technology, but just to say um, uh, there are sort of new innovative ways to improve our testing. Many are probably familiar with PCR testing. It's something that we heard a lot about during the pandemic. And there are other ways of performing tests. For example, we use CRISPR-Cas13 based tests, which we think ultimately will be scalable and lower cost with high sensitivity um, through through continued optimizing of the technology. So one of the things that we're all about is developing platforms, technological platforms that are um, uh, affordable enough that they can be um, deployed widely, not only in the US, but in LMICs. One example we have is our Carmen platform, which tests up to 24 pathogens simultaneously for hundreds of samples, all in one sort of integrated chip. And you'll see the chip here. This is a microfluidic platform, which takes samples and portions them out into very small reaction wells so that we can do very high throughput uh, testing, similar to PCR testing, but multiple pathogens at once, multiple samples at once. And so we see this as one aspect of increasing testing capacity that we think is going to be important and also very achievable with relatively modest equipment investments and training of staff to run this workflow. We've actually had quite a lot of success, uh, and our partners in West Africa rely on these screening platforms regularly now. This is an example of the types of panels that we include on the Carmen platform. So simultaneously, we'll test for all of these viral pathogens. Many of these are hemorrhagic fevers, which are of real concern in the region. Lassa fever, for example, is endemic in Nigeria, Sierra Leone. Um, we're also concerned about the reemergence of some of these other hemorrhagic fevers. And they all present somewhat similarly as febrile illness, making it challenging to do differential diagnoses, especially in a rural clinic setting. Another aspect of our sort of genomic technology that we like to share is we've developed protocols for fairly low cost metagenomics, where you take a sample and identify all of the different viruses that are present in that sample. This is really important in case of the emergence of a disease X or something that has not yet been seen or identified. And generally, we see quite a lot of febrile illness that doesn't have a known pathogen as the causative agent. And so we're starting to develop greater capacity to do metagenomics at low cost, which we think is going to help us learn quite a lot about circulating viruses and other pathogens, causing a great deal of uh, illness, morbidity, and mortality um, across the general population. We develop a whole series of computational tools, and I'm going to talk about these in just a moment when I talk about the Mpox response in Sierra Leone. But these are computational tools that take information about the genetic sequence of the viruses that are causing illness and uses those to understand both the evolution of the virus, understanding under selective pressure or just through ordinary evolutionary processes, how the virus might be changing, how that might change the transmissibility or other characteristics of the outbreak, and actually tracing individual chains of transmission if we have enough data so that we can start to understand at a micro level characteristics of an infectious disease outbreak. So these are computational tools that operate on the viral genetic sequences, the genomes from the viruses that are collected as cases present in a surveillance setting. And we have a data platform called Lookout, which links all of those genetic sequences from the viruses with case data from the patients that presented with illness, and then allows both interaction as well as some level of analysis, interpretation, and prediction, um, bringing sort of traditional case-based epidemiology together with genomic epidemiology, and putting all of those methods in a single data visualization and analysis platform. So this is another sort of example. We use Lookout. Actually, it has different modules, and so we use Lookout for quite a few different functions, depending on if we are screening routinely or responding to an outbreak. And I'll say a little bit more about that later on. So just sort of offering an overview of operationally what is happening now with our Sentinel program. We're conducting ongoing routine surveillance, typically for febrile illness, but also respiratory illness, as patients present to our different health clinics that are connected by spokes back to the central laboratory. And so to date, I think we were a little bit slow to get started. The first 2 years of our program were entirely about COVID and under some restrictions as far as travel and collaboration. But since then, I think we've collected 14,000 samples and conducted over 100,000 tests. We've detected over 3,000 previously unknown cases, including HIV, malaria, Hep B and C, dengue, Lassa, Mpox, and Anyonyong disease. These data they're owned and kept in West Africa, either at Sierra Leone or Nigeria for now, with the groups there. They've formed the basis for research papers on Lassa fever, dengue, and currently we're looking at circulating undetected orthopox in Sierra Leone. So there's been quite a lot of scientific work that's come from the data collected through the Sentinel program. It's a good example of how surveillance underlies a lot of downstream research, simply building the capacity to collect samples, do confirmatory testing, perform viral sequencing, and make those data available through data systems that allow our whole network of collaborators to conduct research has been really important. And for the one of the founding principles of our program is that those data remain in West Africa. Their research studies are almost always led by scientists in West Africa, and so it's a democratization not only of data but also of science and scientific opportunities. Maybe the last thing I'll say before I shift gears and talk about what's happening right now in Sierra Leone is to say that we've sort of put all of our different components together in a typical workflow. For example, in Nigeria, our workflow, we see febrile cases of unknown origin that present at one of our clinics. And the first thing that we would like to happen is we may be able to perform point of care testing on the spot, at least for a limited number of diseases of concern. But often those samples will be collected and shipped back to our hub laboratory where they can be batched, and then using the Carmen platform, we'll conduct multiplex testing. So a positive at point of care is important that would be transmitted back to our Lookout platform as a positive test, but we can only do a limited amount of point of care testing, so we send all of the negatives back to the hub laboratory for batched multiplex testing. Some fraction of those negatives will then go on for metagenomic sequencing so that we can identify potentially unknown or not known to be circulating viruses that we weren't testing for specifically. All of our positive cases will go on for viral sequencing, and then we'll sort of accumulate the genomic data that are useful for some of our computational tools, and everything flows into the Lookout platform for visualizations, reporting to public health authorities, and other both research and surveillance uses. So this is sort of a holistic view of what the surveillance workflow looks like, and each sort of point of this diagram represents an important investment of technology to strengthen surveillance capacity in these countries. I'll just say a little bit as I have my closing portion of this talk is to say what's happening in Sierra Leone. So there's it's relatively recent outbreak, although we think that the first confirmed case was on January 10th. That prompted a national public health emergency. We were called in to support response and surveillance efforts about 3 weeks ago, and we've been sort of going full speed ever since. In Sierra Leone, there's been nearly 4,000 confirmed cases, and this represents almost half of the total number of confirmed Mpox cases in Africa this year. The cases are growing weekly. It's very concerning. We hope that we're going to get a handle on this outbreak. There was a recent news article about this in Nature magazine, or Nature, the journal Nature, I should say. We have a post on all of the data that we've collected up until now. It's on Virological, which is a discussion forum where genomic scientists post the very fast-moving data that we've collected as outbreaks unfold. So it's not peer-reviewed, but it is a go-to source for genomic epi information. And what we've learned, based on a limited convenience sample of 77 cases, we successfully produced 75 genomes from that. So 96% of the samples that we had available, we were able to sequence successfully. This was a partnership with Kenema Government Hospital and the CPHRL, which is the National Reference Laboratory in Sierra Leone. And so those are two of the most capable laboratories in the country, and we've collaborated with both groups. Kenema Government Hospital is one of our Sentinel sites. And so I won't go too far into the weeds here, except to say that we have identified a single dominant lineage, which is driving the current outbreak in Sierra Leone. Again, it's very concerning. The closest relative in terms of the available data on Mpox sequences, the closest relative outside of Sierra Leone are 4 sequences from the United States, and at least 2 of those cases had a history of travel to Nigeria. So we suspect that this has been going on for some time, but it's a little bit hard to parse out exactly what the history and the evolution of this current lineage might be. But I think we're getting closer to that as we get a better understanding of and collect more samples to get a better understanding of the evolutionary dynamics. Based on our the computational tools we have are actually quite good at sort of estimating time to most recent common ancestor. And so we used a couple different methods, including Delphi, which is one of our Sentinel developed tools. It looks like this current outbreak, the lineage goes back, it split off sometime in November of 2024, which means it was circulating for at least 1 or 2 months prior to detection in January of 2025. And that you can infer something about the transmission dynamics from the viral sequences. And so if we just look at those viral sequences without looking at case counts, the inference is that this outbreak has a doubling time of roughly just over 2 weeks. So again, fairly concerning in terms of the growth rate right now of the outbreak. We have another tool called Juniper, which infers from the genomic data from the tree that you can construct based on viral sequences. We can start to understand something about transmission networks, the probability of lines of transmission, and something about the basic reproductive number of the virus at this moment in time. So we have an R naught estimate that is right around 2. And again, we estimated our first case probably originates back to mid-November of 2024. We can make some estimates of the total number of infections based on some assumptions about the mutation rate of the virus, and also some assumptions about the sampling fractions that we've collected. We don't believe there are any likely transmissions directly between the 76 cases that we have sequenced. But keep in mind that those sequenced cases really represent less than 1% of total infections. The last thing I'll say on the genomic data is that there's no evidence right now of geographic clustering. So in fact, we have identical sequences that are detected across geographically distinct districts, which again sort of suggests to us that this is quite a widespread and actively growing outbreak, which again causes us some concerns. I think one thing to note here is if we look at the um, epidemiology of the cases so far, unlike previous Mpox outbreaks, which tended to tilt towards a more heavily male population affected, this is almost 50-50 males and females. We think that it is not transmitting through typical sexual networks the way that past outbreaks have. And so what we're seeing is quite widespread transmission across a fairly broad population, again, causing some concern. I mentioned Lookout. One thing that I will say is when we already had Lookout running in Sierra Leone, but we had not connected all of the different laboratories in the country to provide data. We've done that. And we had an Mpox module running to focus just on this outbreak response less than 6 hours after we got the call to provide support. And so this just gives another example of how important it is to have um, tools in place and modular tools that we don't need to deploy uh, in their entirety so that we can act quickly when an emergency public health situation is occurring. I think that's the way that we want to provide support. We're finding out now that there is a whole range of additional needs, things as simple as providing additional tablets for groups to do data collection and as public health officials are responding, to delivering the reagents that are needed to perform PCR testing and other confirmatory tests, even something as important but simple as helping to facilitate repair of certain equipment, since often the manufacturers of the laboratory equipment don't maintain staff on the continent of Africa, and so it can be quite challenging to do an emergency repair. These are all things that our extended network through the Sentinel program has provided some additional support and capacity to assist the officials in Sierra Leone as they're struggling with a difficult outbreak. So in terms of our next steps for Sierra Leone, I think we're going to continue sequencing positive samples, and we plan to collect and sequence up to 1,000 samples, which we think will give a much better understanding of how this epidemic has unfolded and where it might be going in the near future. So that's happening right now. Both the Broad and IGH sent several team members to our sort of home base in Sierra Leone, and they've been working with government officials as well as other laboratory staff pretty much around the clock for the last 2 weeks. We'll continue to provide ongoing assistance and support genomic and epi analysis in collaboration with the Ministry of Health and the National Public Health Agency in Sierra Leone. They've been very enthusiastic to adopt Lookout as a helpful tool, and so that's actually been really encouraging to see how some of the tools that we developed can not only are working effectively, but we've built enough trust with our colleagues to see those tools adopted really for national response. And this response has also been an opportunity for us to understand how we can support data pipelines with our ultimate goal to be providing real-time analysis and action, and delivering the tools and the technology that will make that possible. We want Sierra Leone to have a state-of-the-art surveillance capacity that they own themselves and that they can operate themselves. And that's really what drives a lot of our work, is to understand from working side by side with our colleagues there how we can support that goal. So that's my presentation. I just offer some closing thoughts very briefly. We do see Sentinel as offering a model for how we can develop an integrated surveillance system in LMICs. We rely a lot on our technology stack, but it's a modular design, so it's sort of pick and choose the components that are most useful. And we see this as complementing existing systems, not trying to replace them. And so the goal here is to offer something that maybe fills in some existing gaps as a short-term solution, with the long-term solution being to help integrate these practices into national and regional public health surveillance and response. The last thing I'll say, and I'll close on this, is that there was a time when, well, even now, I think we talk about genomic surveillance as something that's distinct and different from traditional surveillance, which, again, many of the methods haven't changed too much since the 1980s or even earlier. I do think that we're getting to a point where we won't think of distinct fields of genomic surveillance or genomic epidemiology and mainstream public health practice. That in fact, what we'll see is that these genomic tools will simply become part of the routine standard public health practice, including surveillance and response. And again, they're not replacing things that we've done for 200 years, but they complement the traditional methods that will continue to be useful and helpful, such as contact tracing, on the ground outbreak investigations, et cetera. I just want to acknowledge, there's been a lot of discussion around federal funding for global health. We're actually in an unusual position in that the Sentinel program was entirely funded through philanthropy, and that's left us relatively untouched, although we've had quite a hard hit to other federal funds. But for the Sentinel program, we're very grateful for our funders. I want to acknowledge them here and simply say that there's quite a large team that has contributed to all of this work. And I simply can't name them all, but to say that it's a wonderful team, and we're very grateful for the work of our colleagues. And with that,
Wonderful.
thank you all.
Yeah, thank you so much. We have a little bit of time for questions, so I'll dive right in. But I must say, you spoke about RNA and dashboards all in the same talk, so it was great to see such a spread. So I think there's lots of different ways we could go with the questions, but I'd like to start with maybe some of the tech questions, the technology questions. And you mentioned just modest equipment advancements might be needed. I think that was the term you used. Like earlier today, a colleague of mine who runs a big program on the continent was talking about the challenges of doing creatinine testing for her patients. And so you also talked about, repairing the machinery. And can you give a little bit more perspective on, the type of technology that's used in the labs, and also maybe where, like how many of these would you expect to see in one country in a future vision of this integrated surveillance? I think that would help those of us who maybe don't spend as much time in laboratories.
Yeah, absolutely. So, most countries in the region have laboratories that are set up to do something like PCR testing, for example. They have the equipment that's needed for that. And, that's the equipment is not, it's expensive, and but it's not out of reach for many of the national laboratories there. And in fact, I mentioned in Sierra Leone, there's at least 2 laboratories that have capacity, and we work with both of them. There's quite a few more that can perform PCR testing. That's sort of the level at which all of our tools are designed to work at a laboratory that's outfitted in that way. It's still very challenging, anything from freezer failure to a shortage of a particular reagent could become a bottleneck. But in terms of sort of the availability and the expense of the equipment, it's within reach for many places. We expect, we generally work with 1 hub laboratory per country, but in Sierra Leone now we've made such close ties with the National Reference Laboratory, we'll probably continue to work with them. And the more hub laboratories that are available, the more spokes can connect to them, and the greater the reach. Nigeria is challenging for different reasons because of it's sort of highly federated. It's a very big country, much bigger than Sierra Leone. And so it would probably need more laboratories to sort of cover the whole country. We're concentrated in the south and southeast around Ede, where Redeemers University is based. And as we think about scaling, we're often finding that it's the spoke sites, the rural clinics are sort of priorities for us to expand. And in those places, they probably do not have the laboratory facilities needed to run PCR tests and things like that. And so our point of care testing is an important sort of complement to clinics in those settings, so that they can do some testing on the sort of at the point of care and then uh, send samples back to the hubs. So I don't know if I answered your question, but I think that, you should imagine laboratories that are capable of running PCR tests, of which there are many in the region, often simply need, sometimes they need additional equipment. They'll need supplies, consumables, reagents, and then they will sometimes need training on additional sort of protocols that we use for metagenomics or high throughput screening.
Great, thanks. You mentioned about your funding, and thankfully this project wasn't impacted by federal funding changes. But have you seen, or are you anticipating any other challenges as it relates to the federal government, the US federal government engagement with global entities, especially because I'm thinking you're working with pathogens that, are of concern in terms of global health security, and yet on the other hand, you also stated that the data stays in West Africa, it's owned in West Africa. Is that something not of worry at the moment, or something to be thinking about? Could you share a little bit about that?
Yeah, oh, sure. I mean, it's a great point to raise, and I think there's a lot to consider. I think, compared to many of my colleagues, I actually appreciate that there are some real concerns about, for example, I know there's quite a lot said about things like gain of function research, dual use concerns. Those are, I don't want to be dismissive of those concerns. And I think it's something that we're going to have to be more thoughtful about, to be honest, going forward. Um, you know, Most of the difficulties that we've had right now have been sort of mundane, but it's things like being less confident that some of our international staff, our scientists that are here on U.S. visas, are not as confident to travel back and forth these days. That's a real problem for us, as we have quite a number of talented scientists that simply can't travel back and forth the way that they used to. I think that, the philanthropic community has been attentive to issues of global health. I have a real concern that as capacity from the federal government goes down to fund this kind of research, that's going to put an even greater burden on the philanthropic community. And I'm sure that they will step up, and they cannot replace the funding that used to come from the U.S. government. So those are some of my thoughts about what's happening here. And in terms of, I think there are legitimate concerns about uh, sort of the data, the potential uses of data, the potential um, uh, for sort of bad actors. Having said that, I actually think that those concerns are real and should be considered, probably outweighed by the concerns that we all have about the increasing risk of emerging infectious diseases. And, as I said, go back to 2014, 2015 to see what a very disruptive hemorrhagic fever outbreak looks like. Aside from the cost of life, it was just a very difficult event. And I think that, we would be remiss to take our eyes off of what's happening in the region.
Yeah, thanks. I mean, from my perspective, you've shared such a great sense of what an international collaboration can look like in terms of surveillance, care of patients, collaboration, etc. Yet I think we as a community still have a way to go to be able to translate that message to a more general audience. So that's something to work on. I'm going to leave with one question, because 3 or 4 people in the audience have asked, how can they get involved? How can they do this kind of work? And the questions are coming from someone in Latin America, someone in the School of Public Health here at Harvard. What's a good way to get involved in this kind of work, or what advice could you give our audience members who are interested in that?
Wow, it's wonderful. I mean, I will say, I mentioned that the Sentinel program really came from a deep and lasting partnership between Christian Happy and Pardis Sabeti. So what I've learned is the most important things we can do are to engage and to get to know our colleagues in other parts of the world, learn how we can work together, listen to where they are struggling, how we could produce a fruitful collaboration. And it must be a partnership. It cannot be sort of a one-directional relationship. So my first thoughts, I mean, certainly if anybody has questions about Sentinel, I would love to hear from people. But my thought is engage with the global community. The global research community is actually, despite what's happening sort of at the governmental level and the difficulty of maintaining those collaborations, my experience is that people around the world are really crying out to collaborate. And we've certainly learned more and gained more from the partnership than we think we've put into it. And so it's all to say that sort of collaboration and partnership is the way I would encourage people to get involved.
Fantastic. Well, that's unfortunately all we have time for today, but it's been wonderful having you with us. Thank you so much. And to our audience, thanks for joining us. We're taking a break from the research sessions for July and August, but those will be back in September. Meanwhile, on Fridays, once a month, we have other types of discussions about what's happening in global health. So watch out for those events and please join us. Thank you so much, Dr. Ozonoff. It's been wonderful. Really appreciate you.
Thank you. And it really was a pleasure. And like I said, I'd be glad to take more questions offline if that's possible.
Great. Thanks a lot.